If you walk into a standard schedule operating room, you're usually walking into this environment of just, absolute engineered calm.
Right, it's very controlled.
Exactly. I mean, the environment is perfectly controlled. The team has spent, days reviewing high-resolution scans, and the surgeon is completely prepared to execute this delicate, definitive, highly methodical repair.
Yeah, that's the ideal scenario.
Yeah.
It is a space that is literally designed for meticulous anatomical perfection.
But when you step across the threshold into the trauma resuscitation bay, that entire paradigm just
Oh,
shattered.
completely. It's a different world.
Right, because when a patient arrives in the middle of a catastrophic event like, massive crush injuries or high velocity ballistics or non-compressible torso hemorrhage, the environment isn't just unforgiving. It is actively working against you.
Yes.
The patient's physiology is collapsing, the anatomy is completely unrecognizable, and, that safety net of time is just completely gone.
You are operating in a state of profound ambiguity. I mean, the luxury of a 2-hour theoretical deliberation simply does not exist when a patient arrives in extremis,
Extremist meaning?
meaning they are in the midst of profound cardiovascular collapse. They are actively dying right in front of you.
Wow. Which brings us to our focus for you today. We are taking a custom deep dive into a medical text that completely strips away the polite theory of surgery, right? It gets right into the bloody, tactical reality of keeping a human being alive when the clock is literally ticking down to zero.
It really does.
We're extracting the vital architecture from the Trauma Surgery Code, a comprehensive illustrated atlas of damage control and critical care operations.
It is a truly remarkable piece of work. I mean, the author, Dr. Atef Ahmed, has created this high-yield manual. It's over 200 pages long.
Yeah.
But what really sets it apart, what makes it so unique, is that it features over 140 photorealistic operational illustrations.
It's just wild to look at.
It is. It's designed specifically to bridge the gap between those heavy, text-dense traditional textbooks and the actual tactile split-second execution required in the trauma bay.
And before we get completely lost in the sheer mechanical intensity of this text, because it gets intense, I want to make sure you know that for a limited time, you can actually get this atlas at 50% off.
Oh, wow. Yeah. That's an incredible resource to have visually. I mean, if you want to follow along with the structural concepts we're discussing today, you can access it directly at books.dradef.net.
Right.
And it's also fully available as an ebook or paperback or hardcover on Amazon and Lulu. Dr. Ahmed even has it accessible through his Patreon.
Yeah, highly recommend checking those out. And, the pedigree of the author actually explains a lot about why the book is structured the exact way it is.
Absolutely.
Because Dr. Atef Ahmed is a consultant surgeon in Egypt, right, dealing directly with these critical trauma scenarios on a daily basis. But his background extends far beyond the operating room. He's also a web developer and an Android application programmer.
And when you look at the architecture of the book, that polymath background becomes glaringly obvious.
How so?
Well, someone who codes and builds applications, they think in terms of algorithms, right? They think about user interfaces, about removing friction and stripping away the noise to achieve a very specific output.
Oh, like streamlining the code.
Exactly. And Dr. Ahmed has applied that exact systemic logic to human trauma. He has removed the dense, wandering paragraphs of academic theory.
Which nobody has time to read when someone is bleeding out.
Right. And he replaced them with a purely visual, algorithmic architecture of survival.
He calls it an algorithm of precise, aggressive, and immediate anatomical control. And right in the preface, he lays down a mandate that sets the absolute tone for the entire text. He writes, "In trauma, you do not rise to the level of your expectations. You fall to the level of your training."
That is the core philosophy you have to adopt the second you enter this world. When you are facing an exsanguinating patient, muscle memory and ingrained spatial awareness just have to take over.
Because there's no time to think.
You are navigating the golden hour, and cognitive overload will kill the patient just as surely as the bleeding will.
Wow. Okay, so let's adopt that mindset and look at the first massive psychological hurdle the book forces a surgeon to overcome. We are looking at the first 1 to 4 hours post-injury.
Right, the initial critical window.
Now, my assumption, and I think the assumption most of us have when we watch medical dramas on TV, is that if someone's internal organs are severely damaged, the surgeon's job is to take them to the OR, find every damaged vessel, sew up the lacerated liver, meticulously reattach the bowel, and completely close the patient back up. you fix the broken machine.
Right. And if you attempt to do that on a critically injured trauma patient, you will almost certainly kill them on the table.
Wait, really? Because the sheer time it takes to do a definitive repair is too traumatic.
The time, yes, but more specifically, it's the biochemical environment of the patient's body during that time. The book outlines a massive paradigm shift here. In the chaos of the trauma bay, the primary goal is not definitive anatomical repair. The goal is damage control. You must prioritize physiological restoration over anatomical perfection.
I want to break down what physiological restoration actually means on like a molecular level, because Dr. Ahmed focuses really heavily on something called the lethal triad.
Yes.
He paints this triad as the absolute ultimate enemy in the operating room. It consists of hypothermia, coagulopathy, and acidosis.
Right. And they aren't just three separate problems.
Yeah.
They are a self-sustaining, cascading death spiral.
A death spiral. Okay, let's trace the mechanics of it.
Sure. So when a patient is experiencing massive hemorrhage, they are losing circulating blood volume.
Obviously.
But blood doesn't just carry oxygen, it carries core body heat. As they bleed out, they rapidly lose temperature, they become hypothermic.
And a cold body isn't just shivering, right? From an engineering standpoint, the body's internal machinery just stops functioning at the right tolerances.
Precisely. The coagulation cascade, which is the complex series of proteins and enzymes in the blood that link together to form a physical clot, that cascade is highly temperature dependent.
Okay.
Enzymes are essentially microscopic locks and keys, and when the ambient temperature drops below, say, 34 degrees Celsius, their physical shape alters. The keys no longer fit the locks.
Oh, wow. So the hypothermia directly causes the coagulopathy. The blood literally loses its physical ability to clot.
Exactly. It becomes thin and just keeps flowing.
So you're bleeding because you're cold, and you're cold because you're bleeding.
Right.
So where does the acidosis come in?
Because the patient is bleeding, there aren't enough red blood cells to carry oxygen to the tissues.
Yeah.
The cells in the liver, the muscles, the kidneys, they still need energy to survive. Deprived of oxygen, they're forced to switch from highly efficient aerobic metabolism to a desperate backup system.
Anaerobic metabolism.
Anaerobic metabolism, yes.
Which produces energy, but it kicks out a massive amount of toxic byproducts, right?
Yes. It floods the bloodstream with lactic acid. The pH of the patient's blood drops rapidly. And here is where the trap snaps shut. That acidic environment further denatures those clotting enzymes.
Oh, no.
The acidosis makes the coagulopathy even worse. It also severely depresses the heart muscle's ability to contract.
So if a surgeon tries to stand there for like 6 hours performing a beautifully precise microvascular repair on a shattered liver, the patient is getting colder, they're getting more acidic, and they're bleeding faster the entire time.
Exactly. The surgeon might achieve anatomical perfection just in time to declare the patient dead.
Man.
The damage control philosophy dictates a brutal but absolutely necessary alternative. The surgeon must get in, aggressively pack the liver with surgical pads to provide physical tamponade.
Just shoving gauze in there to stop the bleeding.
Right, just packing it tight. They staple off the ends of the leaking bowel without bothering to reconnect them, leave the abdomen completely open but temporarily covered, and immediately evacuate the patient to the intensive care unit.
It's an absolute triage of priorities. I mean, if I'm thinking about this in mechanical terms, it's kind of like dealing with a catastrophic failure in a submarine.
All right.
If the hull is breached and water is flooding the engine room, you don't, like, break out the manuals and start meticulously rewiring the main propulsion system.
Yeah, you drown.
You slam the watertight doors, you shove emergency patches into the crack, and you pump the water out just to keep the vessel from sinking. You can rewire the propulsion system tomorrow, assuming you actually survive today.
That is a highly accurate structural analogy. You are prioritizing the immediate survival of the chassis. You are buying time to take the patient to the ICU, warm their core temperature back up, pump them full of fresh clotting factors, and reverse the acid buildup.
Right.
Only when their physiology is stabilized, which is usually 24 to 48 hours later, do you bring them back to the OR for the definitive reconstruction.
Okay, to execute that initial slam the watertight door strategy, the trauma team needs immediate high-volume access to the patient's circulatory system.
Yep.
If the patient has lost half their blood volume, you have to push fluids and blood products back into the pipes. But Dr. Ahmed points out a massive mechanical problem here.
Right, the veins.
Yeah. When a patient is in profound hemorrhagic shock, the standard approach of putting an IV into a peripheral vein like, the ones in your arm, becomes physically impossible.
Well, think about the physics of a vein. It's a thin-walled, flexible tube. It relies on the internal pressure of the blood volume to stay plump and open.
Like a water balloon.
Exactly. When a patient is exsanguinated and their blood pressure bottoms out, those peripheral veins completely collapse. They flatten out like a deflated balloon. An IV needle simply has no physical target to enter.
And the text is incredibly strict about this. It mandates a 90-second rule. If the team cannot secure peripheral IV access after 2 attempts or 90 seconds, they must immediately abandon the veins. The algorithms do not allow you to stand there fishing around in a crashing patient's arm.
Because every second wasted is brain tissue dying from hypoxia. You must establish a central conduit immediately.
And the alternative method detailed in the atlas is violently aggressive. We're talking about intraosseous, or IO, access. The illustrations for this are intense. The surgeon takes a specialized powered drill and drives a needle directly through the cortical bone, usually into the proximal humerus, so right near the shoulder joint, or into the proximal tibia below the knee.
It looks severe, I agree. But the anatomical logic behind it is flawless. If we look beneath the hard, calcified outer layer of the bone, we find the medullary cavity.
The marrow.
The marrow, exactly. This cavity is packed with highly vascularized marrow. It contains a massive, intricate network of venous sinusoids.
But unlike the veins in the arm, this network is encased in a rigid structural vault.
Exactly. Because the venous plexus is housed inside solid bone, it's structurally non-collapsible.
Oh, that makes so much sense.
Even if the patient's systemic blood pressure is absolute zero, and every other vein in their body has flattened out, the medullary cavity remains a wide-open, functional vascular space. It acts like a massive, rigid sponge that can absorb fluids and push them directly into the central circulation as fast as a large-bore catheter placed directly into the jugular vein.
You can't just, drill the needle in, hook up a bag of saline, and expect gravity to do the work.
No.
The text highlights a very specific physical step that is required the second that needle breaches the marrow.
Right. Gravity and standard pump pressure are not enough to overcome the initial resistance of the medullary space. Inside that cavity, the vascular network is embedded in a thick matrix of fat and structural proteins. Dr. Ahmed refers to it as the marrow fibrin network.
So it's essentially plugged up with its own internal scaffolding?
Yes. So the atlas mandates a rapid, incredibly forceful 10 cc flush using a syringe. The surgeon must physically blast that fluid into the bone to forcefully expand the sinusoids and blow out that microscopic fibrin architecture. You are violently clearing a cavern inside the bone for the subsequent fluids to enter.
And this leads to a stark clinical pearl in the book. If the trauma patient happens to still be conscious, which is a terrifying prospect, you absolutely must push 2% cardiac lidocaine into the bone before you execute that high-pressure flush.
Yes. The endosteum, which is the membrane lining the inside of the medullary cavity, is heavily innervated with unmyelinated pain fibers. Blasting fluid into that confined, rigid space causes a rapid spike in intraosseous pressure.
It's essentially expanding the inside of the bone outward.
And the patient will interpret that pressure as excruciating, deep visceral pain. Pushing the lidocaine first numbs those intraosseous nerves, allowing the team to establish the life-saving flow rate without sending the patient into neurogenic shock from the sheer pain of it.
Okay, so the IO drill solves the problem of how to pour fluid into a collapsing system.
Right.
But what if the system has a massive, unclamped leak at the bottom? Let's say the patient has a shattered pelvis or a ruptured abdominal aorta from a high-speed collision. You can pour all the blood you want into the shoulder, but it's just going to immediately pour out into the abdomen. You have to shut off the main water valve.
Historically, managing severe, non-compressible torso hemorrhage was one of the most desperate scenarios in all of medicine. The traditional approach was the resuscitative thoracotomy,
which involves taking a scalpel, making a massive incision across the left chest, using a rib spreader to physically crack the rib cage open, plunging your hands into the chest cavity, moving the lung out of the way, and manually applying a steel vascular clamp directly onto the descending aorta.
It is an incredibly invasive, highly morbid procedure. You are inflicting a massive new trauma on a patient who's already dying.
Yeah.
But you had to do it to stop the blood from pumping down into the bleeding abdomen and force whatever blood was left to go up to the heart and the brain.
But the atlas details an endovascular alternative that completely rewrites this approach. It's an intervention that sounds like science fiction. REBO-A.
Yes, REBO-A.
Resuscitative endovascular balloon occlusion of the aorta.
REBO-A is a masterclass in minimally invasive damage control. Instead of cracking the chest open to clamp the aorta from the outside, the surgeon controls it from the inside.
Right.
Using ultrasound guidance, they puncture the common femoral artery down in the groin. They introduce a wire, and over that wire they thread a catheter that carries a deflated, heavy-duty balloon. They feed this catheter up through the arterial system, directly up into the main pipe of the aorta, and then they inflate it.
You are literally inflating a balloon inside the garden hose to block the flow from the inside out.
The balloon expands, physically conforming to the inner wall of the aorta, completely occluding it. The downstream hemorrhage is instantly halted, and the afterload on the heart immediately spikes, preserving the perfusion to the brain and the myocardium.
But Dr. Ahmed maps out the aorta with extreme geographic precision. You can't just inflate this balloon anywhere you want.
No, you absolutely cannot.
The book divides the aorta into strict zones. Zone on is measured up to the sternal notch-like, the base of the neck, and that's utilized for severe intra-abdominal bleeding.
Correct.
Zone 3 is lower down, measured up to the umbilicus, and that is specifically for isolated pelvic fractures. But looking at these schematics, there is a glaring omission. The text jumps from Zone 1 to Zone 3. It explicitly forbids inflating the balloon in Zone 2. Why skip the middle?
This is a critical point of anatomical geography, and the book puts a massive capitalized warning on it. Zone 2 of the aorta is the segment that houses the origins of the major visceral vessels.
Okay.
This is where the renal arteries branch off to feed the kidneys, and where the superior mesenteric artery branches off to feed the entire intestinal tract.
So if you inflate the balloon in Zone 2, the balloon itself physically covers and blocks those specific exits.
You immediately, directly cut off the blood supply to the kidneys and the gut. You will induce rapid, catastrophic visceral and renal ischemia. You might temporarily stop the pelvic bleeding, but you ensure the death of the patient's internal organs.
Wow.
The occlusion must always happen safely above these branches in Zone 1 or safely below them in Zone 3.
And even when you place it perfectly in Zone I, you haven't solved the problem, you've just paused it. The Atlas dictates an incredibly strict, unforgiving time limit. Once that balloon goes up in Zone I, you have an absolute maximum of 30 to 45 minutes of occlusion time.
Because the concept of damage control is always a double-edged sword. By inflating that balloon in the chest, you are saving the brain, but you are intentionally suffocating every single organ below the balloon.
Right.
The liver, the intestines, the kidneys, the legs, they're receiving zero oxygen.
The ticking clock starts the second the balloon inflates.
If you leave that balloon up for 60 minutes, the bowel tissue begins to suffer irreversible necrosis. The cells die. But even if you get the patient to the operating room within 30 minutes, find the bleeding artery and tie it off, the most dangerous moment of the entire procedure is yet to come.
Deflation.
Yes. The book spends significant time detailing the lethal physiology of deflating the Reboe balloon.
This is where that lethal triad comes roaring back, right? Because while the bottom half of the body was suffocating, those cells didn't just go to sleep, they switched to anaerobic metabolism.
Exactly. They spent the last 30 minutes desperately producing energy without oxygen, and in the process, they generated massive pooling lakes of toxic lactic acid, potassium, and inflammatory cytokines in the stagnant blood vessels of the legs and the abdomen.
So if a surgeon just casually deflates the balloon all at once,
They open the floodgates. All of that built-up, highly acidic, potassium-rich blood is instantly washed back into the central circulation. It slams directly into the heart.
Oh.
The sudden acid load depresses the myocardium, and the spike in potassium can instantly trigger a lethal cardiac arrhythmia.
Furthermore, you are suddenly opening up thousands of miles of empty, dilated blood vessels in the lower body.
That's the vasoplegic effect.
Yeah.
The resistance drops to zero, and the patient's blood pressure falls off a cliff.
So what do you do?
The text is adamant. Deflation requires intense, synchronized communication between the surgeon and the anesthesiologist. It must be done partially and incrementally over several minutes.
Just a little at a time.
Right. And the anesthesia team must be actively pushing massive doses of vasopressors and fresh blood products into the central line before the surgeon even touches the syringe to let the air out of the balloon.
The anticipation required there is staggering. You have to treat the complication before you even cause it.
You really do.
But, as intense as Rabo is, we are still dealing with a relatively standard mechanical failure, a broken pipe. The Atlas transitions into scenarios where the body's own normal, healthy anatomy actively becomes the obstruction to survival. This brings us to a section that requires a complete cognitive reset. The perimortem cesarean section, which Dr. Ahmed more accurately terms the resuscitative hysterotomy.
This is arguably one of the most profound examples of shifting paradigms in all of emergency medicine. When a woman in the third trimester of pregnancy suffers massive trauma and goes into cardiac arrest, the standard, universally taught algorithms of CPR simply fail.
I'm trying to picture the sheer mechanics of doing CPR on a patient carrying a near-term infant. I mean, I imagine the physical mass of the gravid uterus makes compressing the chest difficult, but is the failure primarily a circulatory issue?
It is entirely a circulatory hemodynamic obstruction. We have to look at the massive physiological adaptations of pregnancy. By the third trimester, a gravid uterus requires a massive blood supply, holding up to 30% of the maternal cardiac output at any given moment. But the more critical issue is structural. When the mother is laid flat on her back on a trauma gurney, that heavy, fluid-filled uterus falls backward and rests directly on top of the inferior vena cava.
The vena cava being the massive main pipe that returns all the deoxygenated blood from the lower body back up to the right side of the heart.
Exactly. The sheer weight of the uterus physically crushes the vena cava against the maternal spine. It completely clamps the pipe shut. So a trauma team could be performing absolutely flawless textbook chest compressions, physically squeezing the heart.
But the heart is empty. There is no blood returning from the lower body for the heart to actually pump forward. You are squeezing a dry sponge.
The mechanical compression ruins the preload, effectively rendering CPR useless. Therefore, the Atlas outlines an incredibly stark, counterintuitive objective.
Okay.
When a trauma team executes a resuscitative hysterotomy in the setting of maternal cardiac arrest, the primary overwhelming goal of the procedure is maternal resuscitation.
The infant's survival is actually secondary.
Yes. The rationale is that the absolute best chance the infant has for survival is a mother with a beating heart. By rapidly incising the abdomen and physically emptying the uterus, the surgeon instantly relieves that massive weight off the inferior vena cava.
The pipe opens back up.
Immediately. The venous return to the heart is restored, and the efficacy of the chest compressions dramatically improves. Furthermore, once the infant and placenta are delivered, the now empty uterus naturally clamps down and contracts.
Like it does naturally after birth.
Right. And this rapid contraction acts like an autotransfusion, squeezing a significant volume of maternal blood back into her central circulation right when she needs it most.
So the surgical act of the delivery itself is actually a resuscitative maneuver to restart the mother's heart.
It's a profound life-saving intervention for the mother first.
The tactical specifics Dr. Ahmed lays out for this are completely driven by the clock. He details the 4-minute rule. If the mother goes into cardiac arrest, the trauma team has exactly 4 minutes to attempt standard resuscitation pushing epinephrine, trying to manually displace the uterus to the side. But if there is no maternal pulse at the 4-minute mark, the surgeon must initiate the cut, with the goal of delivering the infant by minute 5.
You cannot hesitate. You cannot wait for ideal sterile conditions or the perfect surgical instrument tray. And the physical method detailed in the illustrations reflects this absolute need for speed.
Because normally, for a C-section.
Right. In a standard elective obstetrical C-section, surgeons use the Fanon-style incision, that low horizontal bikini cut. It's cosmetically appealing, and it navigates carefully between the abdominal muscle planes.
But Dr. Ahmed includes a specific bolded warning. Do not waste time with the Fanon-style cut.
Because a horizontal incision forces the surgeon to dissect through multiple complex fascial layers and manually stretch the rectus muscles apart. It takes several minutes. In a resuscitative hysterotomy, the surgeon makes a massive vertical midline laparotomy. They take a large scalpel and cut straight down from the xiphoid process, the very bottom of the sternum, all the way to the pubic bone.
You are bypassing the complex muscle layers entirely and cutting straight through the linea alba, the connective tissue line, right down the center of the abdomen.
It provides instantaneous, wide-open exposure of the entire abdominal cavity in seconds. The surgeon incises the uterus vertically, delivers the infant, hands the infant to the neonatal team, and then manually sweeps out the placenta.
And even the closure of the uterus reflects the damage control mindset. The text notes you don't spend 20 minutes doing a beautiful 2-layer uterine closure.
No, you don't have time.
You throw a rapid running locking suture, or you literally use heavy metal towel clips just to clamp the bleeding edges of the uterus together, pack the abdomen with gauze, and shift focus back to the mother's hemodynamics.
Again, you are prioritizing physiological survival over anatomical perfection.
Okay, let's fast forward. The team has successfully navigated the absolute chaos of the 0 to 4 hour window. The Reboe balloon stopped the pelvic exsanguination, the IO drill delivered the fluids, the hysterotomy restored the maternal pulse. The patient has survived the trauma bay.
A miracle in itself.
Truly. But now they're in the intensive care unit, and the trauma team is facing a completely different kind of marathon. They have to deal with the delayed structural fallout.
This is where we transition into the complications and the rebuild. Securing the patient's physiology is only the first hurdle. The interventions that save their life often create complex architectural problems that require intense management days or weeks later.
And some of these delayed complications sound like structural nightmares. Let's look at the chest first. The atlas covers VATS decortication. So the patient suffered major chest trauma. Blood pooled in the pleural space, the cavity around the lungs. The initial trauma team placed a large plastic chest tube to drain that blood, which is standard. But what happens if the chest tube doesn't catch it all?
We have to look at the biological behavior of blood outside of the vascular system. Blood left in the pleural cavity doesn't just stay a warm liquid. Over a period of days, the inflammatory cascade triggers it to coagulate. It turns into a dark, jelly-like hematoma.
Okay.
And as the body attempts to heal this foreign presence, fibroblasts migrate into the clot. It undergoes a process called organization.
So it's not just a clot anymore, it's becoming living tissue.
So it becomes a dense, thick, fibrous rind. And unfortunately, this rind forms a tight envelope, completely coating the outside of the lung, specifically adhering to the visceral pleura.
If I'm visualizing this mechanically, it's like pouring wet concrete over a rubber bellows. When the concrete sets and hardens, it doesn't matter how hard you pull the handles, the bellows cannot physically expand.
That is an excellent way to conceptualize it. It creates a condition known clinically as a trapped lung. The lung tissue itself might be perfectly healthy, but the patient cannot oxygenate because the lung physically cannot inflate against that hard, fibrous shell.
So how does a surgeon dismantle a concrete shell without destroying the fragile lung underneath?
This requires a highly precise intervention known as videoassisted thoracoscopic surgery, or VATS. Timing is critical here.
When do they do it?
The surgeon aims to intervene between day 3 and day 7 post-injury. You have to wait long enough for the initial bleeding to stop, but you must act before that fibrous rind truly calcifies into bone-like scar tissue.
The illustrations of this are incredibly detailed. The surgeon inserts endoscopic cameras and long articulated instruments through small incisions between the ribs.
And the mechanical goal is pure decortication, literally peeling the bark off the tree. The surgeon has to find the microscopic millimeter-thin plane between this tough inflammatory peel and the shiny, exquisitely delicate visceral pleura of the lung.
That sounds terrifyingly delicate.
It is. Using a combination of blunt sweeps and sharp dissection, they painstakingly strip this rind away, liberating the lung surface.
And the crucial test comes at the end of the procedure, while they are still looking through the camera.
Yes. The surgeon asks the anesthesiologist to apply positive pressure ventilation. They force a deep breath into the patient via the endotracheal tube. And the surgeon watches through the monitor as the newly liberated lung physically re-expands, filling the entire thoracic cavity, proving that the structural cage has been broken and that they haven't inadvertently torn the lung tissue during the dissection.
It is pure mechanical liberation, but, as intricate as that chest reconstruction is, the complications in the abdomen require an entirely different level of structural engineering. We talked earlier about the necessity of leaving the abdomen open during initial damage control to prevent compartment syndrome and allow for bowel swelling.
Right.
But leaving the organs exposed creates a terrifying vulnerability. The atlas dedicates significant space to managing the dreaded ECF, the interocutaneous fistula, in a hostile, open abdomen.
A fistula is, by definition, an abnormal connection between two spaces. Entero refers to the bowel, and cutaneous refers to the skin or the outside environment.
Okay.
In this scenario, a hole has spontaneously opened in the wall of the exposed small intestine, and it is actively leaking raw bowel contents directly into the open abdominal wound.
Beyond the obvious systemic risk of massive bacterial sepsis, what makes this specific fluid so structurally dangerous to the healing wound?
You have to consider the biochemistry of the small intestine. Enteric fluid isn't just waste. It is packed with highly active digestive enzymes, amylase, lipase, and powerful protease. These enzymes are literally designed by evolution to break down complex proteins and lipid bilayers.
They're designed to digest meat.
Precisely. And if that fluid leaks freely into a wound, It cannot differentiate between a steak you ate for dinner and the patient's own healing granulation tissue, fat, and muscle. The enteric fluid will aggressively chemically digest the abdominal wall. It excoriates the surrounding tissue, melting it away.
It is literally digesting the patient from the outside in. And the natural instinct of any surgeon would be to rush back to the OR, grab some sutures, and sew the hole in the bowel shut.
And Dr. Ahmed explicitly warns that doing so is a catastrophic error.
Really? Why?
You cannot surgically close a fistula in an acutely inflamed, completely frozen, open abdomen. The bowel tissue is so edematous, so swollen and friable, that the moment you pull a stitch through it, the tissue will simply tear like wet tissue paper. You will turn a 1-centimeter hole into a 5-centimeter hole.
So you can't sew it. You just have to manage it. The text introduces an overarching protocol acronym here, SNAPP. Sepsis control, nutritional support, because they are leaking all their calories out of the whole anatomy definition, protection of the skin, and plan.
Protection of the skin and the surrounding wound bed becomes the immediate daily architectural battle. You have to physically isolate the caustic digestive fluid away from the vulnerable tissue.
And the specific architectural technique that Atlas details for this is genius. It's called the donut isolation technique. It's a masterclass in hybrid wound plumbing. Can you walk through the mechanics of how they actually build this?
Absolutely. The engineering goal is to create a bespoke, watertight dam around the leak, while simultaneously promoting the healing of the massive wound around it. First, the team takes a highly moldable, putty-like stoma barrier ring.
Like modeling clay.
Similar, yes.
Yeah.
They carefully sculpt this ring and press it securely around the exact mucosal bud of the leaking fistula, creating the donut.
Okay, so you've built a physical retaining wall right at the source of the leak.
Next, they employ negative pressure wound therapy. They take a large sheet of black polyurethane foam and cut it to the exact dimensions of the entire open abdominal wound. But crucially, they cut a central hole in the foam that perfectly matches the outer diameter of that barrier ring.
Oh,
They place the foam into the wound so that the barrier ring sits perfectly flush inside the cutout, isolating the bowel opening.
and there is a massive capitalized red text warning in the book right at this step. The black polyurethane foam must absolutely never come into direct contact with the exposed pink mucosa of the bowel.
Because of the physics of negative pressure. When you apply a vacuum to that black foam, the foam violently contracts. It causes macrodeformation of the tissue it touches, which is great for stimulating blood vessel growth in muscle or fat.
But on the bowel.
But if that contracting foam touches the phageal wall of the intestine, the mechanical friction will rapidly erode right through the serosa and create multiple new fistulas. The foam must only ever touch the stoma ring.
It's an incredibly delicate tolerance. Finally, they seal the entire abdomen with a wide, clear, adhesive drape, creating an artificial outer skin. They cut a small hole in the drape perfectly aligned over the central donut hole, and they attach a standard ostomy bag directly over it.
The result is a structural marvel. The clear drape and the vacuum foam draw the massive edges of the wound together underneath, while the ostomy bag on top safely catches the caustic digestive acid and funnels it away without a single drop ever touching the raw tissue.
It is true architectural salvage, buying the patient the months they need for the inflammation to subside so a definitive repair can eventually be attempted.
Precisely.
Which provides a perfect segue. Let's say the patient survives the fistulas, the infection clears, and the internal organs finally heal. The surgeon is still left with a massive physical defect.
Right.
The patient might be missing a 20-centimeter wide section of their abdominal wall or huge swaths of tissue from a mangled leg. The surgeon has to somehow stretch, borrow, or rearrange the patient's remaining anatomy to close these impossible gaps.
We are shifting now into the realm of advanced soft tissue reconstruction. This is where the surgeon truly has to think like a structural engineer. Consider the abdomen. If an abdomen has been left open for 6 weeks, the massive rectus abdominis muscles, the six-pack muscles in the center, have laterally retracted.
Both pulled away from the middle.
They have pulled far apart to the sides of the body. You have a massive gap in the center covering the bowels.
And you can't just grab the two edges with heavy clamps and force them together in the middle. The sheer mechanical tension would rip the stitches directly through the muscle fiber the second the patient coughed.
Exactly. The abdominal wall is a dynamic high-pressure system. So the surgeon must utilize procedure 13.2, component separation. To understand this, you have to look at the layered fascial architecture of the torso.
Okay.
The central rectus muscles don't just float there. They are tightly tethered to the sides of the body by the broad, sheet-like aponeurosis of the external oblique muscles.
They are essentially anchored to the flanks.
Precisely. Component separation is a biomechanical release. The surgeon makes incisions down the lateral flanks of the patient and intentionally incises or cuts that specific layer of the external oblique aponeurosis from the ribs down to the pelvis.
By cutting that lateral
You
anchor.
instantly release the lateral tension. The central rectus muscles, along with their underlying fascial layers, are suddenly freed. They can physically slide medially toward the center of the abdomen.
The book states that this specific fascial release allows the muscles to advance up to 10 centimeters per side. That's 20 centimeters of total slack generated just by altering the tension lines.
You are fundamentally restructuring the load-bearing design of the patient's torso to achieve a tension-free midline closure, safely restoring the structural domain of the abdomen without resorting to massive synthetic meshes that could get infected.
It is brilliant mechanical manipulation, but what about the surface? What about replacing the skin itself? The Atlas details procedure 12.1 split-thickness skin grafting. When you have a massive degloving injury on a limb, the surgeon harvests a thin layer of healthy skin from a donor site, like the thigh. But the illustration shows them taking this harvested sheet of skin and running it through a hand-cranked machine that looks like a pasta maker covered in tiny blades.
That device is a skin mesher. It cuts a precise geometric pattern of tiny offset slits into the skin graft. Now, the common assumption is that we mesh a graft purely to increase its surface area like pulling on a fishnet. So a small piece of donor skin can be stretched to cover a much larger wound defect, often at a 1.5-to-1 ratio.
Which is incredibly useful, but the text emphasizes that stretching is actually the secondary benefit. There is a far more vital, fluid dynamic reason for those little holes.
When you place a freshly harvested skin graft onto a raw, open wound bed, that wound bed doesn't stay dry. It is going to actively weep blood, serum, and inflammatory exudate.
Right.
If you lay a solid, unmeshed sheet of skin over that wound, all of that fluid gets trapped underneath. It pools and forms a hematoma or a seroma.
It essentially forms a massive blister directly under the graft.
And that fluid physically lifts the skin graft off the underlying nutrient bed. This is catastrophic because a skin graft is entirely dependent on its new bed for survival. The meshed holes act as essential drainage fenestrations. They allow the weeping blood and serum to easily escape through the graft into the outer dressings, ensuring the skin graft remains intimately, physically glued to the tissue below it.
Because the biological process of how that skin actually survives on a new site is fascinating. It's not like plugging in an electrical cord where it instantly has power. The Atlas breaks down the survival of the graft into 3 distinct chronological phases.
Yes, for the first 48 hours, the graft survives purely via plasmatic imbibition. It acts exactly like a dry sponge. It passively drinks up the nutrient-rich plasma and oxygen diffusing out of the raw wound bed just to keep its cells alive.
It's just soaking up ambient nutrients. What's phase 2?
Phase 2 is inosculation. This is the incredible moment where the severed capillary networks on the underside of the skin graft physically align and connect with the tiny capillary buds growing upward from the wound bed.
They are literally matching up the microscopic plumbing pipes.
Exactly. And once the pipes are connected, you enter the final phase, neovascularization. True, systemic blood flow begins to actively circulate through the graft, permanently integrating it into the body.
Wow.
But here is the critical point. All 3 of those phases require absolute, uninterrupted microscopic physical contact. If a hematoma lifts the graft, or if shearing forces slide the graft even a millimeter, those fragile capillary pipes break, the inosculation fails, and the graft turns black and dies.
Okay, but understanding those 3 phases leads directly to a massive glaring problem when dealing with extreme skeletal trauma.
Right.
I was looking at the extremity salvage section, specifically dealing with an open tibia fracture like a motorcycle crash, where the tissue is ripped away and the shin bone is completely exposed to the air. The text includes a definitive rule. Bare cortical bone devoid of periosteum will not accept a skin graft.
It cannot. The outer surface of cortical bone is hard and relatively avascular. It does not possess the dense capillary networks required to provide the plasma for imbibition, nor can it sprout the capillary buds needed for inosculation. If you lay a perfect skin graft directly onto bare white bone, it will simply starve, desiccate, and die.
So if you have a massive crater in the lower leg with 6 inches of dead white bone staring back at you, how do you close it? You can't graft it, and you can't just leave the bone exposed to the air, or it will inevitably develop osteomyelitis, a deep bone infection, and the leg will have to be amputated.
If the local real estate is bankrupt, You have to bring in your own rich, vascularized tissue from elsewhere. You have to perform a pedicled muscle flap. And for the exposed tibia, Dr. Ahmed details procedure 12.2, the gastrocnemius rotation flap.
The structural manipulation required here is awe-inspiring. You are essentially dismantling the patient's calf to save their shin.
The gastrocnemius is the large, powerful twin-bellied muscle that makes up the bulk of your calf. The brilliance of utilizing the medial head of this muscle lies entirely in its vascular anatomy. Its primary blood supply, the medial sural artery, enters the muscle very high up, right near the back of the knee joint.
Okay, so the main power cable feeding blood to the muscle is plugged in at the very top.
Right. Knowing this, the surgeon makes a long incision down the back of the calf. They identify the distal end of the muscle down near the Achilles tendon, and they physically cut the muscle away from its lower insertion. They dissect the entire bottom half of the muscle belly, completely free from the surrounding tissue.
But they don't cut the top.
They meticulously preserve that upper medial sural artery. So you now have a massive, thick piece of muscle that is detached at the bottom but is still wildly alive, is still pulsing, and still bleeding because its main upper blood supply is fully intact. This is what makes it a pedicled flap rather than a free flap.
And then they physically swing it.
The surgeon creates a wide subcutaneous tunnel through the fat of the leg, and they swing or rotate that living, bleeding belly of muscle out of the back of the calf and lay it directly into the massive defect over the exposed tibia bone in the front. They suture it into place.
You have taken this avascular exposed bone and buried it under a thick, highly vascularized blanket of living muscle.
You have immediately completely eradicated dead space. And because this muscle brings its own massive systemic blood flow, it delivers high concentrations of intravenous antibiotics directly to the fracture site, drastically reducing the risk of bone infection. And finally, because the outer surface of that muscle is incredibly rich in capillaries.
Now you can place your meshed skin graft over it.
Exactly. The transposed muscle provides the perfect nutrient-rich bed to support the plasmatic imbibition and inosculation of a new skin graft. It is an absolute masterpiece of utilizing the body's own collateral architecture to salvage a limb that otherwise would have been lost.
It is staggering. I mean, the extreme anatomical manipulations required to save a leg, or reconstruct an abdominal wall, or restart a mother's heart by delivering an infant, they all rely on one absolute truth that this book hammers home on every page.
Yeah.
The surgeon must possess the spatial awareness to know exactly what is biologically possible and the audacity to execute it without hesitation.
Which brings us back to the overarching philosophy of the trauma surgery code. If we zoom out from the specific procedures and look at the totality of Dr. Atef Ahmed's masterclass, we've traced a remarkable journey.
We really have.
We started in the absolute, unmitigated chaos of the 0 to 1 hour trauma bay, drilling directly into marrow cavities, inflating balloons inside the aorta to choke off bleeding, performing chest-cracking resuscitation. We moved through the calculated restraint of damage control packing livers and intentionally leaving abdomens open to prevent a lethal triad of cold and acid. And we finished with the meticulous, highly engineered architectural reconstructions in the ICU component separations, rotational muscle flaps, and complex fistula isolation.
And what strikes me most deeply is the mental framework required to navigate that entire arc. In the conclusion of the atlas, Dr. Ahmed reflects on what he calls the enduring mandate of the trauma surgeon.
He states very clearly that the field of trauma surgery requires a unique, almost unnatural tolerance for ambiguity.
Yeah.
You are never, ever going to have perfect information. The anatomy will be distorted by blast injuries or crush forces. The physiology will be collapsing faster than your monitors can track it.
Right.
Success in that environment does not belong to the surgeon who knows the most esoteric theoretical pathology.
Success belongs to the practitioner with the spatial discipline, the algorithmic mindset, and the absolute calm to execute the correct intervention at the correct moment.
As he writes, in the face of trauma, the prepared mind acts, while the unprepared mind reacts.
It's a profound operating philosophy, and it leads me to the thought I want to pass directly on to you as we wrap up this deep dive. We've spent this entire time exploring these concepts in the intense, high-stakes, blood-soaked context of a surgical trauma bay.
Right.
But look closely at the core underlying logic of damage control surgery. It is the conscious, difficult choice to prioritize immediate physiological survival over perfect, beautiful reconstruction. It is the hard-won wisdom of recognizing that attempting to perfectly fix every broken piece all at once will actually cause a total systemic
It
collapse.
is the discipline of putting out the fire before you attempt to rebuild the engine.
Precisely. So think about your own life, your own career trajectories, or your own personal crises.
Mhm.
When things suddenly shatter, when you are hit with your own version of an unexpected, chaotic trauma, what is your instinct? Are you trying to immediately fix every single thing perfectly, creating massive internal stress and pushing yourself further into a spiral? Or can you find the discipline to just stop the bleeding first? Can you secure your base, apply damage control, and simply survive your own golden hour, trusting that you will have the strength to begin the definitive rebuild tomorrow?
A vital, clarifying question to carry with you, no matter what field you operate in.
Thank you so much for joining us on this deep dive into the trauma surgery code. Remember, the incredible visual architecture we unpacked today is laid out brilliantly by Dr. Atef Ahmed, and you can explore the precise anatomical corridors in those 140 photorealistic illustrations yourself. Check it out at books.dratahef.net or on Amazon. Until next time, keep your training high, rely on your algorithms, and stay curious.